All right, good evening and welcome to today's webinar. I'm Danae Aber, I'm the Healthcare Innovation Supervisor with Well Ahead Louisiana. Thanks so much for joining us. Do want to note that your lines are muted so we can prevent background noise, but feel free to enter questions into the Q&A box at any time during the presentation. And we'll actually have a brief Q&A towards the beginning, and then we'll have another one at the end of today's presentation. Today's webinar is the third in our Telehealth and Practice webinar series presented by Dr. Ted Hudspeth, and it will talk about the pre-visit workflow for a telemedicine visit. If you weren't able to join us for the first two sessions, the recordings are available on our website for you to view at your convenience. All the sessions of the webinar series, which are listed here, will be recorded and they'll be available on the website at walpen.org/telehealth. And we'll also have some on-demand sessions posted on the website within the next couple of months, so stay tuned for those. This webinar series is funded in part by the TxLaw Telehealth Resource Center. TxLaw is a HRSA-funded program at Texas Tech University designed to provide technical assistance and resources for new and existing telehealth programs in Louisiana and Texas. And TxLaw is partnered with us at Well Ahead to serve as the support representative for Louisiana providers. And then as a reminder, TxLaw is one of 12 regional TRCs across the US, and there's 2 national TRCs, the Center for Connected Health Policy in California and the Technology Assessment Center in Alaska. The 12 regional TRCs and 2 national TRCs form the National Consortium of Telehealth Resource Centers. And as a consortium, the TRCs have an unparalleled amount of resources to help with telehealth education and technical assistance, and it's available to providers at no cost. And with that, I will hand off to Dr. Hudspeth for today's presentation.
Well, thank you so much, Danae. I appreciate all of you joining me right now. Today, we're going to talk about journeys, really. And I want to start off saying I started my journey in a very small town in rural Louisiana, Amite, Louisiana, for those of you who don't know. And, you know, I do feel a connection with all of you where you are in your practices. I really wanted my practice to be in a very small town. And when I moved back home, I was planning on moving back home. My wife decided she wanted to be a little closer to Walmart back then. So we ended up moving to Hammond. And Hammond's not too much bigger, but we certainly enjoy being in a clinic that services a lot of rural folks. So we do draw from those areas. And I wanted to say something else about my journey. This telemedicine thing that we're doing here, I feel so blessed to have become a part of my institution's, I guess, endeavor into trying to figure this out and how we do it, starting back in 2018. And, you know, as everything happened with the pandemic, you know, we were really right at the right place at the right time. And all of the work that I did with that really, I guess, kind of shine a light on my interest in computers and telemedicine and reaching out in different ways to people, you know, innovating care and stuff like that. And I recently was honored to become the new medical director of informatics for Ochsner and Baton Rouge. So I am going to start working more with all of the providers and helping them. Actually, what I'm helping you do, learn how to use all of this to reach patients, to care for them in new and different ways that's more convenient, you know, than in other ways sometimes. So that's what the whole purpose of this is really kind of showing you my journey and hopefully making your journey just a little bit easier. When I started all this, I felt like I was winging it, all right? And I'm hoping that what I teach you and show you that I've done, and we've done as a big team in our institution, that might help you some to not wing it and care for people better. So I'm going to talk about really a patient's journey through telemedicine today. And the majority of this is going to be the pre-visit workflow and the things that we're doing with that. But I'm going to show you what actually the patient sees through their entire visit, so to speak. It's going to be what's on the back end. because that's really where the rubber meets the road here. So I'm going to kind of carry you through that whole process so that you can see kind of the ins and outs of what we do on the back end to make a patient's flow and experience better. So a journey of 1,000 miles begins with a single step. And you guys may be doing some of this now, you may be about to do it, but it all starts one step at a time. It's just like everything else. And I wanted to take this opportunity to thank those of you who are logging on every 2 weeks with us and plan to do so in the future. I want to thank you for taking this journey with me, because it's been fun for me to really put down in a PowerPoint all of this stuff that we were doing or are doing now. I'm kind of floored by all of this, because it's taken us a couple of years to do all of this. And here I'm trying to put a synopsis together on that. It's been a challenge, but it's been exciting to do. So thank you all for doing this with me. So Danae, you wanted to ask something about Q&A.
Yes, thank you. So before we jump into the content for today, we did have a request last time to kind of start with some Q&As from the previous lectures, because they're so full of great content that sometimes at the end, people don't quite have their questions ready yet. So we wanted to open up a little bit of time, a few minutes at the beginning before we jump into the content, to give you guys an opportunity to ask any questions you might have from either of the previous lectures, and we'll go ahead and answer those and clear up any questions and confusion that you might have before we move into some new information. So if you have any, please feel free to pop them into the Q&A box at the bottom of your screen. We'll just sit quietly for a minute here and let you guys do that. Well, maybe not quietly. Dr. Hudspeth might have some things to say while we're waiting, but yeah, you guys, if you have questions, please feel free, enter them into the Q&A box, and we'll get those taken care of before we enter the new content.
Yeah, I would like to say something that's kind of on the top of my head that I've talked with a few folks today about. I saw a study that was done where they showed that 40% of people delay or don't visit a provider with an issue because of inconvenience and time restrictions. And what we're doing with telemedicine can really take that away. It just relieves one more barrier that people have with getting somewhere. It's not just the person who is elderly and cannot drive themselves to the doctor that's a problem. It's the guy who works from 9 to 5 and they have to take off of work. It costs them double. It costs them to see you, and it costs them time at their job. And that's really where I've grown the majority of my practice, is servicing those people who wouldn't get to see me otherwise. And hopefully we're taking care of things earlier and getting them the care that they need in a more convenient fashion, but otherwise it wouldn't happen. So I think that's a big point. I love that article.
Yeah, that's a good point. There's a whole demographic, I think, of people who, work a type of job that it's not necessarily easy to be able to take off, or, they don't have sufficient sick time, vacation time. They've used all their sick time on their kids, those sorts of things. And so they can't really take off of work to go to a doctor's appointment.
Yep.
And even though I have sufficient time off that I could take, sometimes, you just feel like, to get to the doctor, it's just, you'd have to take a whole day or afternoon, and it's a whole thing, and you sit in the waiting room, and, it's not that bad. I'll just wait, so that's, but 40%, that's high. It
is high. It is high.
So I'm not seeing any questions here. So I think we'll, if you want to go ahead and get started with the new content.
All right, good deal. Well, I'm going to pop this slide up, and it looks busy, right? But I'm going to carry you through each step of this and show you what's really happening on the back end for patients with this. Okay, so this is going to pop up throughout the presentation, so don't try to digest it right now. Okay. The second thing I'm going to talk about is, you wanted to do a poll right quick, huh? I'm sorry about that. If everyone can kind of go through this poll and answer yes or no, is your office staff involved in working with patients prior to your telehealth visit other than scheduling? So, does your staff interface with people after they get scheduled? Do they do anything between then and when you see them? So we'll see what that is later on when we get everyone's answers. Okay. All right. So I'm going to talk about something that I call the VEEK score. That's kind of a goober way of looking at it. The VEEK score stands for this. And I ask myself when I'm going to implement something in my practice, I want to know what the score is on this. And VEEK stands for, first of all, well, can you take that off, Danae? There we go. The V stands for value. What the things that we do should have added value to the patient and their care. So I look at the V. Next on the list is E for efficiency. What efficiencies is that change bringing to me as a provider in caring for that patient? The second E is experience. And I want to say that's not just patient experience. That's the buzzword now. I want to know what's the provider experience in this. I'm the one who has to do this all the time. So I want to know how is that affecting me in my flow with patients and being able to efficiently care for them. And then lastly, what's the quality part of that? So is it bringing some type of quality of care to what I'm doing with the patient? Okay, so I'm going to kind of go through each of these points because they all have a great VEEK score, okay? And we're going to summarize that on this grid as we go through this process. All right, so we're going to start off with simple scheduling. Scheduling can occur up to the minute before your visit to, weeks to months before. So I put this up in the top box here just with scheduling because that can happen at any time. But as you can see, I have this grid kind of designed such that we have on the left where patients have a certain thing they do. My LPN and MA have a certain thing they do. And then the provider has a certain thing that they do. And if you look across the top, there's a timeline, okay, from 1 week to 2 days prior, and then after the visit, the day of and after the visit, okay? So for us, what we do, we actually start with, after our scheduling, we go to an online pre-check. But with the scheduling itself, patients can actually do this online or on a phone. Now, the online option, obviously the advantage of that is having less staff have to do those types of things, okay? But the second thing, and to me, more importantly, it's a way for you to engage with patients to have them help you in doing some other things in your visit, okay? And I'll go through all of those things. But the advantages of, besides the decreased staffing costs, is also the ease for the patients. Patients can do this at night when we don't have staff on the phone. And, those are times when families start thinking about, well, I have to get this, that, and the other done for the kids or whatever it is. And it's nice to be able to do that at any time. So their experience is really good with this too. Another thing, patients have told me they really love being able to look at a grid of times I'm available. When they're on a phone with someone, the clerk will say, oh, he's got a 3 o'clock on Friday. Well, that's not good. Okay, maybe something on Wednesday. Well, they have to go through all that grid. With this, they can look at one thing and see it all at one time, and patients love that. So I did this for myself. I wanted to schedule an appointment with my doctor, and I just wanted to show you the experience that I have with this. First of all, I get that grid, okay? And I could pick on that 1:40 appointment. As soon as I do that, it brings up my appointment. It's scheduled, okay? I can just click that green button down at the bottom, and I scheduled this as a virtual visit, okay? From there, I can actually click on visit instructions and get all the instructions of how to do my visit itself, okay? And next, I'm carried into what's called an e-pre-check or an online question series that carries me through a lot of different options, which helps the physician or the provider know exactly, why you're coming in, and it answers a bunch of things that need to be obtained, like the consent. I mean, think about getting a consent. How do you do that if you don't have an ability for a patient to click on something? Do you have to send it to them, email it to them, sign it? How do you do that? You have to think about all that when you're going to roll out a platform. So having the patient go through all of this, it really is, think about the rooming process that your nurse does, okay? And what do you have here? Telemedicine? Are you currently doing telemedicine in your practice? Is this is the old Danae? I got rid of that. I don't know how that popped up. I'm sorry about that. All right, so we're going to talk about the patient's workflow 7 days prior to the visit. What happens here, that online pre-check fires, and they actually receive a text to go and complete their pre-check. And in that, they can go through and look at their meds, clinical questionnaires, allergies and vitals, health maintenance, health histories, and then if they're coming from a referred doctor or referring physician, then they can fill out some of that information. If they don't do it 7 days prior when they get their initial text, they will receive another text 2 days prior to complete that information. So we're going to go through all of this right here. I'm going to go into the nitty-gritty on it. So they get a verification questionnaire, and they basically, this is the stuff that they would normally do when they come into your office to get their name, phone, email, address, and their physical address. And they also get a consent for treatment through telemedicine. There's a lot of ways that you can find those things that need to be in there. I'll end up getting one of those and have Danae post that so that you can see what a sample one is, okay? But it's pretty standard information. So for me, as I was going through my e-pre-check with my physician, as you see, I could go through and click on allergies. And this is actually, it popped up my allergies that are in my chart. You can see I am personally allergic to penicillin and tetracycline. Now, you see, I can click on that to ask that it be removed, but a provider would have to do that after I flag it as maybe a problem. And I can add an allergy here, okay? So these are all normally questions that nurses will ask when they room the patients, but here we're enlisting the patient's help. The second part of this is medications. Now, this is huge. I am so thankful that they put this in place, because what happens is I can, oops, I'm sorry about that. I can go in and click on every single medicine that I'm on and request that it be removed if I'm not taking it anymore, or change how I'm taking it, and I can add medications. Now, think of the good parts of this for you in your practice. This is really an efficiency thing for me when I get it done. I don't have to go through all of that and ask all the questions. Now, I do have to go in as a provider and physically remove the medication if they requested that it be removed. I can have a conversation with, oh, you're not taking your amlodipine anymore, those kinds of things. So I do have to do that, but I would do that in my clinic anyway, okay? So on this particular process here, I gave full checks on everything. I mean, this adds value to me, making sure in a telemedicine world, I'm getting all of those things that are so important to patients' histories, their medications, their allergies, et cetera. So that is a very big value thing that I think many folks in the telemedicine world are not providing to begin with. The efficiencies for me is not having to do all of that work myself. When I first started in a pilot doing some telemedicine visits, I was doing maybe 1 or 2 a day. And it was not a really big deal for me to do all of that. But all of a sudden when COVID hit, and I was having, 15 or 20 patients a day only in telemedicine, oh my gosh, it was a bear. I could not get through my visits. So I was basically doing my nurses and my work, okay, is how I envisioned it, because nobody was rooming anyone. So we had to try to figure this out and figure out a rooming process. And that's really what I'm carrying you through right now. How do we get a patient roomed in the telemedicine space? It's very, very important, but because this also adds down to the bottom line, your quality. I mean, if you're not doing this, then your quality is going to really be hurt because you don't have the full picture on where your patient is and what they're doing at the time. I'm going to go back up to the efficiency thing. You know, if you're having to do all of this, your efficiency is going to stink, and you're not going to want to do this too much longer. So I encourage you to work with your teams to figure out a workflow that works best for you with your particular platform that you're using. Okay. So next we have the clinical questionnaire. Now here is where a patient is able to put in all of their HPI information, chief complaint and that type of stuff, and can fill out a full review of systems. And it is so nice to be able to pull that into a note. You know, there's no reason why I should have to redocument everything the patient's already done. So I'll show you what I did. So I was signing up to go to my doctor for my hypertension. Okay, so that was a checkbox. I could click what my problem was. And from there, it asked several questions. You know, your high blood pressure, is it a new thing or is it chronic? So I could click the button. Next, it asked, when were you first diagnosed? Since you first noticed your high blood pressure, how has it changed? Okay, so this is giving bullet points where we can show the doctor exactly what's happening with my pressure. Next on the list, they wanted to know some review of systems. I answered no to all these because I feel fine now, but I have the option of talking about headaches and things like that. Next, they're asking if we're taking any medications that could affect my pressure, such as amphetamines or weight loss pills, decongestants, and things like that. So that's pretty important to know in a hypertension review of systems. And then, do you have any of the following risk factors for heart disease? I'm overweight. Okay, so I'll fill that out. And then further on, the next things it's looking if we are following any, which of the following are hurting your ability to control your high blood pressure? And I clicked none on that. And then it was asking what type of treatments I've had in the past and if I've had improvement. So you can see this is a pretty extensive review of systems and HPI, and all of that can be brought into my note. So obviously this adds value above what many folks are doing in telemedicine. It also improves my efficiencies because I have all that I can bring directly into a note. The experience for me is phenomenal, okay? For a patient, sometimes they say that, you know, man, I had to click all those buttons. But when I press them on it, they really like the fact that they know I know them. And, you know, I've been a part of another group that we've been looking at some things about, you know, what do people really, really want from their physician or their nurse practitioner? You know, they want them to listen and they want them to know them, okay? With the distance of telemedicine right now, all of these bits of information become ever more important for you to know them, okay? And for them to feel like you know them. So when they put all of that in there and you're able to basically, kind of like you do in a visit, you know how when patients say something to you and then you actively say it back to them, that's one of the acts in a visit that can make them feel like you heard them. This is the same process, but it gives you a ton of information to have an opportunity to do that. And that's one of the things I feel that helps me make a real bond with my patient through, you know, a telemedicine visit. I don't have the physical touch anymore when I do these. So I've got to take advantage of some of these other things that I do or have in the telemedicine world that can make us connect. And information is it. So I think it helps with their experience. And then of course, quality, you know, the more I know about all this stuff, my quality is going to be better. Now, we talked a little bit on our last presentation about obtaining vital signs, and I'm going to talk more about that on the next presentation that I do when I talk about the physician's workflow in all of this. But trying to press your staff, because the staff is the one who really has to do this, pressing them to get the patients to do everything they can to get some vital signs. This is really important. Of course, if you're going to do, diabetes and hypertension follow-ups, you've got to have the data, right? But for our other visits, it's very important too. This is one of our quality standards and value standards that we are looked at by many insurers. So you've got to have this stuff on the chart. For us, we do try to get them to bring in their cuff and have it validated once a year. We actually have a spot in our electronic medical record to be able to document that we did that. So then we feel comfortable going on their numbers. And some platforms will allow a patient to enter those directly into their app, which will go into your chart. Some platforms will interface with things like a Withings blood pressure cuff. Withings is a company, or some other company that's able to Bluetooth or directly connect with their health app, say in the Apple world. Okay, some of those things can be brought in automatically, depending on your platform. So I just highly encourage you to do this and document it consistently. Of course, doing all of these all add value and efficiency, experience, and quality to the care that you're giving when you're doing that process. So next is health maintenance. On health maintenance, this is a pretty big thing for us since my practice has moved towards a chronic care management type practice. Historically, I was about 50-50 chronic care versus acute and urgent care. Well, my practice has changed over the last really, I guess, 7 or 8 years. Insurers have changed, and the whole demographic of how people go to the doctor has changed. So we are very aggressive at this health maintenance business, okay? And a patient can help you with that. Not all patients do all of their studies within our facility. So we have to start pulling all that data from outside and having the patient as the first step in telling us, did you have your mammogram done somewhere else? Well, that helps us start moving into that world and figuring out where to get that information. Of course, I checked all the boxes here too, because knowing the health maintenance on patients really helps their overall care with their chronic care problems. So we also have an ability to be able to have patients check off their problem lists, surgeries, family history, social history, and social determinants, which we all know are becoming ever more important in figuring out how we can best deliver care to patients. These social determinants are very important. And they're somewhat, sometimes it's a little uncomfortable to talk about some of these social determinant things in a visit face-to-face. Having an ability, a patient having an ability to kind of click through those while they're not being pressured with everything else and the speed of a visit and that kind of stuff, this is nice. And being able to pull that into a chart really helps you make some decisions on maybe how to better care for patients and get them the things that they need. So again, I checked all the boxes on that. So referring providers. Now, most of you probably don't have referring providers, but for those who do some consultant work, then you need to have that referring provider information, and you can collect it during that also. So we went through this box right here. That was a pretty long box. And as I told you before, the patient does receive that text 2 days prior again to try and get that information in. But if that doesn't happen, that's where my team goes into action. So 1 to 2 days before the visit, actually they go and start looking at the charting and seeing, what needs to be filled in. So they go and look at the health maintenance box to see if there's been any kind of an update on that. And they start connecting with the patients. They call them and they try to reconcile their health maintenance. So actually in our boxes, we have it prompt to us if they've had their mammogram or not, et cetera. So our team goes through all of that, okay? If the patient has not had that done, then they actually start scheduling it. I mean, they put in orders and send that to me if need be. And if they have had it done, then they start reaching out to get the mammogram from outside the system so that we can have a copy of that. In our world, we have to have copies of all of those to be able to reconcile that and prove that to insurers who we have value contracts with. So I don't know how many of you are doing a value-based business right now, but we will all be doing that in the very near future when Medicare changes to where everything is value-based. So we are going to be really responsible for the entire ball of wax is what's going to be happening as time goes by. And we're going to have all that information. So things that we all look at right now in our system are, we look at the low dose CTs that people who are smokers can get, colonoscopies, fit cards and all that kind of stuff for colorectal screening, aspirin use in patients with cardiovascular risk, statin use in cardiovascular patients, eye exams, foot exams, A1Cs and lipids and microalbumins in diabetics. We look at all their vaccines from influenza, the Prevnar 13, pneumococcal 23, the tetanus vaccine and shingles vaccine, and now COVID. We've got a new box to check. We look at all of that data, and we also check to see if they've had their hepatitis C screening, HIV screening, and for our opioid patients, we actually track whether they've had a urine drug screen annually and signed the contract that they need to sign. So all of those are things that our software helps us with because it turns things red when they're needing to get stuff done. And if it's not red, we don't have to worry about it, okay? So that is, again, where your platform can be a help to you if you choose one that does that. Now, I'm going to talk a little bit about written order guidelines because in this process, if a nurse or MA sees that something is needing to be done, that's a lot of messaging to me to sign orders. Well, we do have written order guidelines, and I wanted to share these with you because the nurses can, if it's for screening and routine things that they qualify for, they can order the mammograms, colons, vision screens, lipids, A1C, urine protein creatinine ratio, TSH, hepatitis screening, urinalysis, UPT, CMP, and the ultrasound for abdominal aortic aneurysm screening. They can order all of that. And that doesn't really require a signature from me going to my inbox. And then, of course, all of our vaccines, that can all be done as you would typically expect. So this is a big help to me with really my efficiencies, the quality, obviously, and the value that we provide to patients by being able to do that. And then that's stuff that I don't have to do in a visit. You understand? So with this, it's awesome because I can spend more time focusing on my patient and the problem that they came to me for. So many of us, I'm sure, are kind of well done with all the boxes we have to check these days, right? And a lot of it is just, it's just stuff that just has to be done. And there's a process for that where people can work to the utmost of their licensure and do these things. And I feel in my practice, the fact that I'm able to have others do some of these more menial tasks or just repetitive tasks, this has helped me with my burnout. I know a lot of you probably feel burnt because you're doing this repetitive stuff that just doesn't use all of your skills. And I've kind of worked this in a way where, man, we can start having some of this stuff done by the team, which makes a whole lot of sense, not only time-wise for the patient, but efficiency-wise and cost-wise for our clinic. It's a really big thing. So we went through health maintenance and calling the patient, and they also look at the med rec and the med reconciliation and make sure that all of that was done by the patient. And if not, then they go through that list and look to see if they need to update it for me. So I told you about the fact that the patient can flag a medicine, whether it needs to be taken off of the board or not. And the nurse can change the recommendations there. Like if a patient's saying they're taking it one time a day when I had written it for twice or whatever, they can flag all of that. But that has to be pinned to me to actually make that final change. All right. And then, of course, if a patient's coming in and just needing medicine refills, well, they can pin all of those medications that the patient needs. They can pin that for refill for me. So when I go into the visit, all that's right there, which is very nice. So we do have a fallback if there are things that haven't been done as the visit's getting closer. Then our MA actually goes in and does a lot of these things when they scrub the schedule just to make sure that everything's been done. They verify meds, all the allergies, updates, and that kind of stuff. They make sure that the pharmacy is on the list that the patient's going to want those medications sent to. Sometimes it's multiple pharmacies, so we have to make sure the meds are going to go to the right one. And some clinics, like in our specialty clinics, they have specific workflows that they need cared for. So you have to think about if you maybe have a specialty clinic of some sort, then you have other things that they can do. Some things that we do have them do once a year, we have, again, this is a value metric kind of thing that we have with our insurers. We do a depression screen, a fall questionnaire, and then an educational questionnaire. This basically enlightens us as to how a patient learns the best and through what method, so that we know how to present information to them to be utilized the best. And then, of course, living will information. That's a point at which they can kind of go through that stuff and get that on the chart. So on the workflow with the provider, this is going to be kind of short, because the next time we meet in 2 weeks, I'm going to spend the entire time on this. You are going to get so much meat in that meeting. It is going to be a lot of information. I'm going to provide you with templates that you can use in your own practice and modify. I'm going to show you how to do all my hypertension and diabetes and all of those types of things with the workflows of the business I have to do with caring for the patient. Okay. So I'm not going to go into great detail into that right now, but just to say, at the time of the visit, I am notified, like our system and platform has a big little video camera that comes up next to the patient's name, and it tells me they're in their visit. It's gotten so fancy now. It links in with my phone, and I get a message on my watch that the patient's in the visit. Okay. If that's not the ultimate of geekdom, I don't know what is, but I'm cool with toys. So anyway, so I am notified about their presence, and I can click on the button, go into the visit. We care for everything. I'm able to review everything that the patient and or the nurse has been able to put into the chart for me. Now, again, I'm going to go back to that connection with the patient. When the patient sees that, they know they entered all that information in, when I can reiterate that to them at that point, that's where we're having that connection. I can add, to that some really great empathic cues. I see here that you've been having a difficult time, with this, that, or the other, that you put in the history here. That must have been difficult for you. If I can take that moment to do those things, that is where I establish a connection with patients. And all of a sudden you turn a very cold, interface across a computer into, me and you. And that is, to me, where I really have loved the telemedicine space, because not everyone's doing that. And I love it when other people don't do something, because when I do it, it makes me special. And it makes a patient want to come back to me in this space. And, you're not going to start your telemedicine program just all of a sudden and bam, they're going to be knocking down the doors. You really don't want to do that, because you're going to be inundated and it's not going to fly very well. Starting with 1 or 2 is all you need. And every single time you do that, you are building a new business model. I mean, think about that. You're building a whole new business or a line of service to people. And at some point, it is going to hit a critical mass. Because if you take care of grandma one time and you did it right, you've got the whole family the next time they get sick. And that's how it's going to grow. So I encourage you to, again, this is a journey. You start with one step. And to me, this is the best way to do it. Okay. Next, the workflow. I complete all of my notes and place orders, drop my charges, and then I have to route that somewhere. And guys, I'm laughing a little bit to myself because, when we started doing this, we just started winging it. And when I got a large number of people, all of a sudden communication between me and my nursing team became a big deal. I had to be able to communicate without being in the same room with them, both during a visit and of course after a visit, because in some telemedicine programs, all they're doing is urgent care. Someone's, calling up with a sore throat or a cough. The doctor sends in a medicine, and you don't really need a nurse for that. Well, that's not my practice. I'm doing a lot of chronic care management. I'm ordering tests on people. I'm scheduling appointments with specialists. I need a staff to be able to do that. So that two-way communication and closed communication. So I send it, I know they got it. That has to be something that you think about, or things are going to fall through the cracks and patients are not going to be well serviced. So we had to do a whole plan on how are we going to get the chart to route to the nurse, who, and how's that going to show up. We did this because we were building it. We were building the program, but you guys are going to be getting a platform of some sort, and you have to think about what do they have to be able to allow you to do these kinds of things. The first thing that they have to do next after you see them in their visit is obviously, let me go back on that. They have to contact the patient, okay, and kind of follow up. So for the patient, their login should be very easy. In ours, they actually have, a one button click that should carry them into the visit. We talked about a platform yesterday I'm sorry, 2 weeks ago, where I texted them a link. They can click on the link and it brings them into the visit. That's pretty simple. It shouldn't be a whole bunch of stuff that they have to do to get in. And when you think about platforms, think about like, what does the patient see when they go into that visit? Think about it. They're in this cold, dark telemedicine room by themselves. How do they know they're in the right place? When are you coming on? So some platforms allow you to have a little message at the bottom saying, the doctor will be with you. You're waiting on Dr. Hudspeth, or, things like that. It also can give an estimated wait time. Some of them have that. And some have a drop-in feature where my nurse, when they see that the patient is in the visit, the nurse could drop in and say, yes, Mrs. Jones, you're where you need to be. He's running 5 minutes late. He'll be right in with you. That kind of stuff. That's pretty nice to be able to do that. Okay. If you can. So let's see. So the patient workflow after seeing the provider is next. On this part, let me move something here. Basically, the staff has to contact the patient and complete all of these follow-up tasks that I gave them, complete all the orders and that type of stuff. And next, the patient should receive a summary of information. That's their after visit summary that we give them in the clinic now. They need to be able to have access to this if possible. Those are very important for patients because, they'll often carry that to their next doctor's visit or to their specialist visit or to their family to let them know what the doctor did on them. So for me, I'm able to click a button and send that directly to my nurse's inbox, and then they can pick that up asynchronously, at some other time and connect with the patient and order the tests and get things done. So on these last things, the routing to the team and the after visit summary, it hit all the check marks on that for my VEEC score. And this is a summary. We hit VEEC score on everything. All right. Of course, this was something that I put together, so I wanted my VEEC score to look great, right? But it truly does. When you go through all of it and seeing what these parts of the visit help with, it's a big deal. So this is a completed workflow of our patient virtual visit journey. A quote here, "The greatest thing in this world is not so much where we stand as in what direction we are moving." So we are starting with one step. You know, we are still very early in this game. Okay, guys, I did happen to get started maybe earlier than you did. But in the big picture, this is still a very early game in telemedicine. You're not too late at all. And you have an opportunity here to build your program like you want it and develop an entirely new service line to help your practice with something that will make it, pandemic proof, like I've talked about in our previous lecture. I felt like being savvy at this telemedicine is what helped my practice survive through that pandemic that we started with last March. It helps with your patient's accessibility, et cetera. We all know the reasons why we should do this, but it takes one step. And I'm so glad that you guys are taking that step with me. A couple of years ago, I went to Canada, actually do some lectures up there. And I found this sign in a shop, and I wanted to share it to you. It's not the destination, it's the ride. And I truly feel like this has been a ride for me. Being able to start a couple of years ago and start building this, and then to see what it's developed into now, and being honored with an opportunity to speak to you guys and share some of the things that I learned as I was winging it. All right. So hopefully you won't have to wing it as much as I did. And with all of the team that you have, with the folks who are bringing this to you, you guys have a lot of resources. Right now, on this, every one of our PowerPoints, we have this resource list that you can go to, and we have references that you can go to start seeing how you might incorporate this into your particular practice. And of course, we have contact information where you can look at all of our previous and future videos at the well ahead at la.gov. And well, that's where you'll go, or either the walpen.org/telehealth. Of course, you can connect with me and ask questions if you need to. And of course, I would like to offer you to answer any questions right now for what I just presented.
All right, thanks, Dr. Hudspeth. I see a thank you again comment.
Thank you.
So we do have the Q&A box ready. I've got it open here. So if you have any questions, please go ahead and type those in and I will read those out. And then I'm actually going to go ahead and share our poll results from earlier. Can you see those, Dr. Hudspeth?
I can. So yes was 17% and no was 50%, and 33% not doing telehealth currently. Excellent. Okay. Well, that's good to know. So what I've shared with you now, for those of you who aren't doing anything beforehand, I think this is very timely to kind of open your eyes as to, look, you don't have to do all of these. I'm giving you the utopia. If I had to build it from scratch, this is what would be in my mind's eyes as the Cadillac. Okay. I don't have all of these pieces in place. The majority of these are in place, but like the drop-in feature that I told you, we don't have that yet. We're working on it. But this, again, I presented you the utopia of things to look for in your particular platform that you choose. So thank you for answering those questions.
All right, any other questions anybody has? Either from this presentation or even from a previous one.
I think Tracy's raising her hand.
Tracy, do you have here? There you go, Tracy.
Okay, you got to unmute me. Thank you. So, Dr. Hudspeth, some of our clinics are eligible to get a free 1-year subscription to DoxyMe. Mm-hmm. It doesn't. I don't know if you've had experience in that. And if you have any kind of thing related to that, or if that may come up in a future session, but we have some clinics in Southwest Louisiana that would be available to be qualified for that program.
That's great for them. So I do have experience with DoxyMe. Okay. I love the fact that I can text a patient and send them a link. I'll be honest, it is, and I'll talk about this, I think, in our last lecture. It is a little amazing to me that even that sometimes is a little difficult for people to find the text, click on it, get their audio and video to work. So, we really do have to make it as simple as possible. That's about as simple as you can make it. And what I really do love about that program is that I also have an opportunity after I click the button to send them the link, I can then click another button and call them. So they'll pick up the phone. They can do that. When they do that, then I can walk them through that step and tell them, look, I just texted you something. Go to your text box, click on the link, make sure you say yes to the audio and video. And then I tell them, because it takes a few seconds to transition. I tell them, and give it a little time. So, it, because it's going to take a little bit to go into the visit, but it'll carry you into the video with me. So that's what I tell them. So I like it because of its ease of use. I have very consistently had a good, reception. I think it's a pretty robust program that probably doesn't use a ton of bandwidth, even though it has video. So it, for me, has worked pretty well in rural areas with rural patients. So I really do like it. It is our second go-to within our system. We have our own primary system that we have kind of built within our organization. And every now and then it has glitches. And when we have a glitch, guess what we go to? We go to DoxyMe. Okay. So what it doesn't afford me is, a lot of the other things, all of the things that I went through today, pretty much, they can't answer questions on review of systems, reconcile medications, et cetera. If any of that is going to be done before my visit, my team has to get activated. Okay. They have to go in and start doing all of that work ahead of time. And again, as I just showed you, when you start thinking about it, you start having a few telemed visits that you didn't have all that done on, man, it's tough to get through the visit and do a good job on what they primarily came there for. Okay. So I'd like to know how their rollout goes. I'm sure they're going to do a fine job with that. And that's a great place to start.
And that, just for everybody, that is just one of the programs that's available. We're not advertising DoxyMe or saying choose that over another one. That just happens to be an opportunity that is available for certain clinics in our state. And I really wanted to, and I know also it's a frequent one that is used by our clinics frequently because of the low bandwidth. So just wanted to make sure what people's experiences with it have been. I'm sure there are lots of others out there.
Yeah, when I was preparing for my previous lecture, and I looked at DoxyMe, that was one of the things that they really touted about themselves, was that they worked in a low bandwidth situation. So
we do have a question in the chat,
okay.
Q&A box. So thank you so much for the valuable information. Is it possible to set up all participants in some sort of discussion group that will help us communicate with each other and Dr. Ted for suggestions as we navigate and set up our programs in the days to come? And I see you smirking, Dr. Hudspeth, because we've actually talked about this.
I'm not going to say a word till you say a word.
This is something we've actually talked about internally, about logistically how we can go about setting up something like that. So thank you for making the comment and asking that question, and we will bring that back and have some more discussions about how we can.
And I did not prompt them to say that.
I think it's a plant.
I'll give the government disclaimer on that. Things get really complicated when you get state government in the middle of it. So that's part of the clearance that we're working on.
Yeah. For whoever asked that question, that was one of my first questions whenever we started this process. And the ladies are working on it. They want to do something like that because I think it would be a good resource. And I don't mind being a part of something like that, but we do need to go through the appropriate channels. So.
Yeah, and I think, Dr. Hudspeth, I think you have maybe some Facebook groups that you're a part of. I don't know if they would be relevant to this group. And these topics that they're not specific to this program, but they may be valuable.
Yeah, I mean, there are several telemedicine or provider telemedicine groups online. You know, Facebook. You can find those and sign up. I mean, they have thousands of providers in it from all over the country. I have felt being in those that there's a lot of negativity to talk about medicine in general. There's a lot of people have difficult times if their systems are not right, and you know, and they vent. So I don't really go in them very much because of that. I don't want to be a part of a lot of negativity. That's just my personality. So I don't have a group that I go to and really recommend right now. I would love to have that with people who are interested in just making things better. And I think that's what you guys are trying to work on. So I'll be happy to be a part of that. Well,
thank you. That's good feedback to know too, that there's not really a place to land at this point.
Yeah.
So we'll bring that back and see if we can wade through the state tape and all the things. We'll give it, I don't see anything else in the chat right now, so we'll give it just, we have 2 minutes left, so we can wait the 2 minutes to see if we get any additional questions in.
Somebody asked something.
Yeah, while we're waiting, I would like to comment on that drop-in feature. That to me, I think is an amazing, really useful feature, that drop-in, because anecdotally and you know, personal experience with family members, you know, especially older family members, they're not sure they've done it right. And so, you know, I think it's helpful to confirm, yes, you're in the right place. Just hold on, we're coming, you know? So I think that's a great feature.
Yeah, I'm very hopeful that they will get that working. That will be so nice, I think. It'll be the extra special touch, you know. You know, I want to go back to talking about that connection. You know, as we move forward in medicine, I believe that you know, patients are this is going to be second nature to them, is just doing telemedicine. I really do think that. And they're going to be able to see anybody in the country, just about. You know, if they want to see someone at Johns Hopkins, you know, they could do it see a Johns Hopkins doctor. Well, what is going to make them want to click my button? You know, what is going to make them want to come to me when they have the entire world that they can go to? And it's going to be that connection. And the connection comes from knowing them and listening to them. So you can listen, you know, easily through telemedicine. You have eye contact and those kinds of things. But knowing them is that other secret sauce piece that I think that engaging with patients and having all of this information at your fingertips is very important. Of course, you guys in the rural area, you live next to your patients. So, you know, you see them at the ball field. So this is not as big a problem for those of you who already know and live near your patients. It's not as big a deal. I know it's hard for me to go to Walmart without doing several consultations while I'm there, you know, in my small town. So that's the beauty of it.
We do have another question here. So could we somehow get a tentative list of features that we would need to discuss as necessary within our EHR system to facilitate the setup of a program?
Okay, if I recall in our resources, let me see if I can go back on that. This on the resources, there's a Texas Medical Association telemedicine vendor evaluation. If I'm recalling this, this was a pretty good list here that you can click on and see things that they've come up with that I think are really good. So I would reference that. And it seems like, shoot, Danae, wasn't there one from the California? There's a California one that has a checklist, and I don't know where that is. I'll have to find that again. But that Texas one is very good. So I would go to that first.
Yeah, it may be under one of the resources. I don't quite remember, but there's so many resources, and if you need something in particular, you know, that's part of what I can do is to help you find that particular document, because the consortium of telehealth resource centers and the Center for Connected Health Policy, the Technology Institute, TextLaw, we all have so many resources. And sometimes it's overwhelming how many resources we have. So if you're looking for something really particular, I can help go through the website and find that document. But if you just go onto the consortium website and look through everything, there's a ton of resources there. So we are actually a little bit over time. So I'm going to go ahead and wrap us up for today. So thanks again, everyone, for joining us. As a reminder, the slides, the recording is going to be available on our walpen.org/telehealth website. There's also a form on the bottom of that page where you can submit questions if you think of some questions after the webinar. Our next one in the series will be at the same time, 5:30 p.m. on February 25th. And it'll talk about the telemedicine visit workflow and documentation. Please feel free to reach out to us at any time with questions in the meantime, and thank you and have a great night.